Benign disorders of the female reproductive tract. Benign neoplasms. Benign neoplasms are non-cancerous forms of tissue growth. Benign means non-cancerous. Neoplasm means excessive tissue growth. Let's begin by looking at some types of benign neoplasms. Polyps are one of the more common benign neoplasms. There are cervical, endocervical, and endometrial polyps. Polyps are benign growths that frequently result from infection. Polyps are most commonly found on the cervix and in the uterus. Cervical polyps can appear after menstruation begins. Endocervical polyps happen in perimenopausal and menopausal women, typically between the ages of 40 and 60. Endometrial polyps are rare in women under 20 years of age, but the likelihood of these polyps increase as the woman approaches their 50s. After menopause, the risk of endometrial polyps declines. The therapeutic management for polyps is removal by forceps during hysterectomy or laser vaporization. Endocervical polyps tend to be cherry red. Cervical polyps tend to be grayish-white. Most polyps are asymptomatic. Mild symptoms might occur, including abnormal vaginal bleeding or discharge. Uterine Leiomyomas, or fibroids. Fibroids are benign growths. Fibroids, when present, tend to grow rapidly during the childbearing years due to estrogen dependency, and they shrink upon menopause. The risk of fibroids is usually highest at around the age of 45. Fibroids can be treated by using gonadotropin-releasing hormone, or GnRH, agonists, progestin agonist, and uterine artery embolization. There are also surgical methods of removal, including myomectomy, laser surgery, and hysterectomies. Hormonal methods to treat uterine fibroids have advantages and disadvantages. The advantages of the hormonal method for removing fibroids is that it is non-invasive, reduces the size of fibroids, and symptoms often improve. Disadvantages of hormonal approaches include serious side effects with some long-term use, and fibroids may regrow if medication is stopped. Another treatment for uterine fibroids is uterine fibroid embolization. This is a minimally invasive procedure that dramatically decreases in symptoms and can preserve future fertility. The drawbacks of uterine fibroid embolization are that the procedure frequently is painful and may require radiation and contrast dye. The procedure includes a permanently implanted material and can possibly negatively impact future fertility. Myomectomy is another approach for uterine fibroid treatment. It is performed as a minor surgery and the uterus is preserved in this procedure. The drawbacks of myomectomies is that it requires general anesthesia and new growth of fibroids can still occur. Another surgical treatment for uterine fibroids is hysterectomies. A hysterectomy for the purposes of uterine fibroids involves the complete removal of fibroids and immediate symptom relief. However, it does require surgery with general anesthesia and fertility is not preserved. Another type of common benign neoplasm is ovarian cysts. There are different types of ovarian cysts. There are follicular cysts, corpus luteum cysts, theca lutein cysts, polycystic ovarian syndrome, or PCOS. Ovarian cysts can be treated, but they first must be diagnosed as either benign or malignant. To determine whether an ovarian cyst is benign or malignant, a transvaginal ultrasound or laparoscopy is usually used. Oftentimes, ovarian cysts can be controlled with oral contraceptives and pain relievers. Another type of benign neoplasm is genital fistulas. Common types of genital fistulas include vesicovaginal fistulas, urethrovaginal fistulas, and rectovaginal fistulas. If the fistulas are small, they usually will heal without treatment. However, if they become large, they may require surgical repair. Bartholin cysts are another type of benign neoplasm. Bartholin cysts come about due to the blockage of one of the ducts of the Bartholin's gland, leading to possible infection and abscess development. Depending on the severity of the Bartholin cyst, surgery may be needed. When the cysts are small, the patient will usually experience no symptoms, but may have signs and symptoms of an infection. Pelvic organ prolapse. Pelvic organ prolapse happens when the muscles and tissues supporting the pelvic organs, including the uterus, bladder, or rectum, become weakened or loosen. When this occurs, one or more of the pelvic organs can drop into the vagina, press into the vagina, or even bulge out of the vagina. Pelvic organ prolapse is associated with many symptoms, including fecal incontinence, chronic constipation, painful intercourse, pain or pressure in the vagina, back or pelvic pain, urinary incontinence, urine retention, vaginal tissue bulges, lack of sexual sensation, and tampons that don't stay in place. There are different types of pelvic organ prolapse. Small bowel prolapse, also called enterocele, occurs when the small intestines, or small bowel, descends into the lower pelvic cavity and pushes at the top part of the vagina, creating a bulge. Anterior vaginal prolapse, also known as cystocele or a prolapsed bladder, is when the bladder drops from its normal position in the pelvis and pushes on the wall of the vagina. A posterior vaginal prolapse, also known as rectocele, occurs when the wall of the fibrous tissue that separates the rectum from the vagina weakens. When this happens, tissues or structures just behind the vaginal wall, in this case the rectum, can bulge into the vagina. Uterine prolapse occurs when the pelvic floor muscles and ligaments stretch and weaken and no longer can provide enough support for the uterus. As a result, the uterus slips down into or protrudes out of the vagina. There are different stages of pelvic organ prolapse depending on how far the organ is removed from its normal position. In stage 0, there is no descent of pelvic structure during straining. In stage 1, the prolapsed descending organ is less than 1 centimeter above the hymenal ring. Stage 2 is when the prolapsed organ extends 1 centimeter below the hymenal ring. And stage 3 is when the prolapse extends 2 to 3 centimeters below the hymenal ring. There are different ways to manage pelvic organ prolapse. One is doing Kegel exercises. When doing Kegel exercises, first make sure your bladder is empty, then sit or lie down. Tighten your pelvic floor muscles and hold for a count of 3 to 5 seconds. Then relax the muscles and count 3 to 5 seconds again. Repeat this 10 times, 3 times a day, morning, afternoon, and night. There is also hormone replacement therapy that can be done to treat pelvic organ prolapse. Many women with prolapsed bladders may benefit from estrogen replacement therapy. Estrogen helps strengthen and maintain muscles in the vagina. There are also dietary and lifestyle modifications recommended for people with pelvic organ prolapse, including maintaining a healthy weight, increasing fluid intake, and increasing dietary fiber. There are also devices for the treatment of pelvic organ prolapse called Pessaries. A pessary is a device that is inserted into the vagina that helps to support the pelvic organs. Many women find immediate relief from symptoms with pessary use. Pessaries are available in many shapes and sizes. They can be used short-term or long-term. Pessary choice is based on the woman's symptoms and the type of prolapse that occurs. Another type of intrauterine device is called the Colpexin Sphere. The Colpexin Sphere is an intravaginal device that elevates and supports the pelvic organs. This device can be used with pelvic floor muscle exercises to treat pelvic organ prolapse. Surgical interventions are also available for pelvic organ prolapse, such as anterior or posterior colporrhaphy. Colporrhaphy is used to tighten and support the tissues that hold these organs in place, restoring their normal position and function. Hysterectomy can also be a surgical intervention for pelvic organ prolapse. Pelvic organ prolapse, or POP, is the third most common indication for vaginal hysterectomy. A hysterectomy is an operation that removes a woman's uterus. A woman may have a hysterectomy for many different reasons, including uterine fibroids that can cause pain, bleeding, or other problems, and uterine prolapse, which is the sliding of the uterus from its normal position into the vaginal canal. The clinical manifestations of pelvic organ prolapse are usually asymptomatic, but may include the feeling of a dragging or a lump in the vagina or something coming down. Pelvic organ prolapse is diagnosed through several means, including physical examination, where pelvic examination can observe obvious protrusions and aberrations in bladder function. Laboratory and diagnostic tests can also be done, including urinalysis, a urine culture, and post-void urine volume tests. Urinary and fecal incontinence. Urinary and fecal incontinence is the inability to hold urine or feces, and leakage may occur. Incontinence is due to weakness of connective tissue and muscle support of the pelvic organs. This is often related to vaginal childbirth, advancing age, doing heavy work, poor nutrition, or an increased body mass. There are 3 common types of incontinence: urge incontinence, stress incontinence, and mixed incontinence. Incontinence involves an interplay of bladder function, pelvic floor muscles, neural control, and integrity of neural connections for voluntary control. Urge continence versus stress incontinence. Urge incontinence is described as the precipitous loss of urine preceded by a strong urge to void, with increased bladder pressure. Stress incontinence is described as the accidental leakage of urine that occurs with increased pressure on the bladder from coughing, sneezing, laughing, or physical exertion. Urge incontinence can be due to neurological issues, idiopathic issues, or infections. Stress incontinence develops commonly in women in their 40s and 50s and is usually the result of weakened muscles and ligaments in the pelvis following childbirth. The signs and symptoms of urge incontinence include urgency, frequency, nocturia or nighttime urinations, and large amounts of urine loss, whereas stress incontinence involves the involuntary loss of small amounts of urine in response to physical activity that raises the intra-abdominal pressure. Management of urinary incontinence. The treatment for the senses of urgency include bladder training, Kegel exercises, pessary rings, anticholinergic drugs, and surgery only if other methods fail. Another management of urinary incontinence is to reduce stress. Stress reduction includes weight loss, smoking cessation, avoidance of constipation, Kegel exercises, pessaries, weighted vaginal cones, peri-urethral injections, medications like duloxetine, and estrogen replacement therapy. As a last result, surgery can be used. There are many reasons that clients don't want to talk about bladder control issues. This is because the patient may feel that urinary incontinence is inevitable and not amenable to any types of treatment, which is false. The patient may also feel that urinary incontinence is just a normal part of aging. The female patient may feel that urinary incontinence is simply just part of being female and that they should accept it. A patient may also consider urinary incontinence a hygiene problem and not a medical condition, which is not the case. Incontinence issues is something that should be taken seriously and talked about with your medical provider. Thank you for watching.